Hi people. So today I'm recording this video to solve certain doubts. One of which would be this message has been sent to me by Gunveer and he's asked me this question. He is not an enrolled candidate, but I did tell him that as and when I get time, I'll record a video and clear his doubt. I have a couple of minutes, so I thought why not help. So I'm recording this doubt of yours, Gunveer. I hope this helps you. And after this, I would be going on about some endo pedo related concepts. I find that many candidates are confused and they have requested me to make a video explaining in which situations you're supposed to do DPC, IPC, CIVEX, pulpotomy, and pulpectomy. Somehow they get confused when questions are asked between primary and permanent teeth. So I'll be saying a few words about that too. So let's start. This is a question and this OPG is given. A 45-year-old male patient presented with a complaint of pain in the upper right front tooth region. Okay, so upper right front tooth are these four teeth. So these two basically the right ones. Here in the question, I'm going to point out the keywords that you're supposed to look for because those keywords are going to point you out to the right direction. Because in such questions, all the options given are almost always correct. So you have to choose the right option always what they want. So basically, this falls under information gathering question and diagnosis and this thing treatment. So this question covers like three aspects of the clusters which ADC mentions: information gathering, diagnosis and management, and clinical treatment planning. Okay. Such a question is 100% going to come in your exam. So be very careful as to how you answer because I'll also show you the variation of the question. If I change certain keywords, the answer would just directly change. Understood? So yeah, there is pain in the upper right teeth. And now see, keywords here are pain was of moderate intensity, intermittent in nature, and was present since 1 month. General health of the patient was normal and medical history was non-contributory. Here the keyword is general health of the patient was normal. Now this normal is very important. I'll tell you why later. Clinical examination revealed tooth 1-2 with a deep lingual pit. Clinically missing 1-3 and root stumps of 1-6. So here the keyword is lingual pit, deep lingual pit with relation to 1-2. Information about 1-3 and 1-6 are irrelevant to us right now because we are being bothered about the front area. Swelling below the eye was noted with temperature of 38 degrees Celsius. So the temperature around the skin below the eye was 38, but the general health of the patient was normal. Understood? The patient is not febrile. The question does not mention that the patient has not eaten since past 2 or 3 days and is running a very high temperature. It's not mentioned in the question. So patient is normal. Only the area of the swelling is a little high and it's a little hot and flushed. 1-2 gave negative response to electric pulp vitality test, which means it's dead, which means it's non-vital. And there is a deep lingual pit, which points directly to what? And it's a lateral incisor. So what is the most common thing? It's dens invaginatus. Like without even going to the question, you should know the answer in your mind. Now let's see the option. Dens invaginatus, that is the right option. Open apex, no. Why? Because the patient is 45-year-old. Then E vaginatus is talon's cusp. And the question mentions there is a deep lingual pit. Vertical root fracture, well, that could have happened. But since the question has gone out of its way to tell you that there is a deep lingual pit, and the X-ray kind of shows this tiny thing out here, the radio opacity, you have to go with dense invaginatus. Impacted maxillary canine. Yes, there is a maxillary canine here out there, which is impacted. But since electric pulp test is not responding here, it means the pulp is non-vital and there is swelling associated, which can also be because of the impacted canine. But the deep lingual pit and the history of pain, impacted canine is not going to cause a pain like this. dense invaginatus can cause. So, hence the answer becomes dense invaginatus. The most common teeth affected by this condition are, of course, lateral incisor. Like, you should know this. This is pathology. Now, what should be the immediate treatment? Now, this was your question, Gunveer, right? What should be the immediate treatment? Because according to you, therapeutic guidelines says you should like refer to immediate hospitalization. See, when are you going to ask the patient to get hospitalized? When the patient is febrile. That's why my keyword was patient's health is normal. If the question said, and you will get a question like this, which will say a 9-year-old boy has come to you with febrile illness. He's having fever since 2 days and he's not eaten properly since 2, 3 days and he's having a big swelling over his, cheek area and there is like dense invaginatus. What are you gonna do? In that scenario, your answer would be immediate IV antibiotics and hospital administration, like get hospitalized. You won't treat such a child because he's febrile. He's not eaten since past 2, 3 days. But in this question, the patient is 45-year-old. That's why the age becomes important. Next, his general health is normal. Now, then you treat it like any other normal swelling. Now, forget it's dense invaginatus or something. Maybe it was another tooth, for example, a 4-5. It had caries and a swelling came, which was like in the submandibular space. You're not going to refer this to a hospital. According to ADC, when the patient is normal, comes to you with a swelling, the first thing that you do is you drain it through intraoral incision. If intraoral incision is not possible, then you drain it through the skin. But you also give antibiotics. So the first step is drainage, and then you would prescribe the antibiotics. Understood? Hence, here the answer becomes B. I hope this is very clear, and I hope it is also clear in which situation you would be referring to hospital emergency. Understood? So that's about it regarding this question. Now I'll be teaching you all a bit about DPC. Let me go here. Let me open images because when I show images, it becomes way easier in your mind to understand. Now, before understanding this, see, you do DPC, you do civex pulpotomy, you do uh, full pulpotomy, you do apexification, you do apexogenesis. What is that one material which you use everywhere? That is calcium hydroxide. Let me speak to you a bit about calcium hydroxide because once you understand the concept about calcium hydroxide, you will understand all other things. So, see, I don't know if you have read this book called as Seltzer. Seltzer is a book which kind of opened my brain windows towards understanding pulp. See, understanding this concept will not only help you to answer all the questions properly, but it will also help you to be a better clinician. Yeah. So sorry, I had to pause the video. A call had come. So we are back on. I think I was speaking about calcium hydroxide and my learnings from this book called as Seltzer. See, when I would like to really be grateful to the author of this book, Seltzer. I mean, it's the name of the author itself has written about just pulp. That 300 pages book is just based on pulp. I mean, we can practice clinically and we can do good treatments and right treatments because, people like Seltzer have devoted their entire lives to understand how the pulp works, how the materials on it works. So, like, I'm really grateful to them that they wrote such nice books on it. And I happened to find this book when I was in the library in my post graduation. Like I remember my library, like Nair Hospital, Dental College in Bombay. It's one of the best libraries in the world. They have books from wow, like 1800s, it's a very vast and huge library. After my clinical hours, I used to just go there, scroll, just get hold of any book and literally sit on the floor and start reading it. And they were so interesting. They were not boring books at all. Like even this pulp book, I just happened to come across and I liked it so much. I requested the librarian to give me the book. I xeroxed it, and it's still with me. So yeah. So in that book, how nicely they had explained the concept which I'm about to say. See, calcium hydroxide is your friend. Okay, it's the friend of the pulp basically. If you have a best friend and you want to say to your best friend, you know what, I want to fly, I want to be on the aeroplane, your best friend would actually cheer you up, motivate you, and get the plane and be the pilot and would just ask you, you know what, hop on and let's fly. If someday you tell your friend that I want to dig a hole in the ground, he will gather the shovel, come with you, and start digging with you. That friend of yours is calcium hydroxide. So it's the friend of the pulp. Now, this concept is very important to understand because now when you see this image, imagine this is a milk tooth. All right. This red portion here is calcium hydroxide and this part of the pulp is exposed. When it's a milk tooth, you have to understand what is the nature of the pulp in this milk tooth. What is the inherent nature of the pulp in the milk tooth? The inherent nature of the pulp in the milk tooth is to resorb. It has high odontoclastic activity going on because eventually the pulp needs to resorb, the roots need to resorb so that the new tooth out here can come up. So, if the pulp inherently possesses the capacity to resorb, and that's its nature in the milk tooth, when you place its friend, that is this calcium hydroxide, it will help it more to resorb the pulp. So what you will end up with internal resorption. Hence, calcium hydroxide is contraindicated as a material for direct pulp capping in the milk tooth, even for pulpotomies. You cannot place calcium hydroxide on a part of a live pulp, even if it's a mechanical exposure, because eventually it's going to lead to internal resorption because that is what the pulp wants to do, and calcium hydroxide would hasten the process. You understand? I hope this is very clear, and never in your life, in your clinical practice, you're going to put calcium hydroxide over a live pulp in a milk tooth. Is that clear? Now coming to the permanent tooth. See, in permanent tooth, what is the inherent nature of the pulp? The inherent nature of the pulp is to repair. It wants more and more dentine to form so that the pulp stays protected because the tooth has to last a lifetime. It doesn't want to resorb. It doesn't want the roots to resorb. It wants to keep on nourishing the tooth. Because if the pulp resorbs, the dentinal tubules which have, the liquids and nourishment that they are getting it from the pulp would go away. The dentin would become brittle and so would your tooth. Hence the pulp wants to stay alive. So when now there is an exposure of the pulp and it was healthy, and you place calcium hydroxide on a permanent tooth which wants to stay alive, calcium hydroxide would cheer up, says yes, let's stay alive. So it will hasten the formation of a dentinal bridge. It would absorb more calcium from the blood vessels and start healing this area, and slowly a tertiary or a reparative dentine would be formed here, and the pulp would again be enclosed in its cavity and stay alive. So the calcium hydroxide material is the same in the milk tooth or the permanent, but what kind of reaction it elicits totally depends on the pulp's nature. So now coming to direct pulp capping. According to therapeutic guidelines in Cameron's and Walton, you will do direct pulp capping only in one scenario, and that is when there is rubber dam around the tooth and you have mechanically exposed pinpoint of the pulp. Pinpoint is less than 0.5 mm. and you have accidentally exposed and you were working under rubber dam. Only in that condition you will be doing a direct pulp capping. You will not be doing a direct pulp capping if a patient had a fall, has a class 3 anterior tooth fracture, and there is pinpoint exposure. Why? Because there was no rubber dam when the patient had a fall. The pulp is contaminated for a bit superficially, so you cannot just put calcium hydroxide directly over the contaminated area. You have to remove a little portion of the pulp, that is called as a superficial pulpotomy or a civex pulpotomy, and then over the clean surface of the pulp, 1 or 2 mm that you have removed, you will place calcium hydroxide. Is that clear? Complete pulpotomy. What is a complete pulpotomy? You are removing the pulp till this area. You see, you're amputating the pulp till the opening of the apex out here. Opening of the root canal, sorry, not the apex. Opening of the canals out here. You're removing this entire portion of the pulp. You do pulpotomies mainly in children. You don't tend to do pulpotomies in adults. There are certain exceptional scenarios, but at your level, you're just supposed to remember that you're going to do pulpotomy in children. Which cases you're going to do pulpotomy? When there is an accidental exposure of a large portion of the pulp when you're working. Or there was caries which was very deep, and when you open the chamber, you don't see that the pulp is too much inflamed. There is no spontaneous bleeding. Like just by putting a cotton, the bleeding stops and you can see the healthy pulp below. In that scenario, you're going to do a pulpotomy. There is no spontaneous pain. The history of the patient is not giving spontaneous pain. What is spontaneous pain, guys? Again, I would quote Selzer here, and I'm very grateful that that person who devoted his life to write this book. It's helped me as a clinician and treat patients and never had any complaints because I understood what the pulp is behaving. So, what is spontaneous pain? See, you see this pulp, it's full of blood vessels and nerves, etc. Now, it's a connective tissue basically. Now, when there is caries and it irritates the pulp and the entire bacterial invasion causes inflammation of the entire pulp. Inflammation, if you would have read in your first year of general pathology, causes vasodilation, and in the tissues surrounding the blood vessels, lot of fluid gets accumulated, which is what happens here. So the pressure kind of builds up. Just a while ago, to all my enrolled group candidates, I had shared the normal amount of pressure of the pulp and an inflamed pulp. The normal pressure of the pulp inside this enclosed walls of dentine is around 14 mm of mercury. An inflamed pulp is around 35. Like it's almost double, more than the double. So when there is such high pressure, it's going to hurt you. Even when you're not eating anything, even when you're not stimulating the pulp, that is called as a spontaneous pain. And spontaneous pain will only happen when the entire pulp is completely inflamed, which means you cannot do a pulpotomy, you have to do a pulpectomy. And you must have seen when you would have done root canals, in certain patients, they come with severe pain. No matter how much LA you give, it doesn't work. You have to give intrapulpal, and the moment you just put the burr in the pulp chamber, like the blood oozes out with such pressure. You cannot find the canals unless you know the anatomy. It's just blood, blood, and blood. And you just blindly, with your knowledge of anatomy, you find the canals and you clean and you clean and you clean. It easily takes like 20-25 minutes. Your gloves are full of blood. Your assistant keeps on suctioning. You put saline, you put hypochlorite. After a while, you can start seeing the tooth when all of that inflammation is out. Compared to any necrotic pulp that you must have opened, you open and it's absolutely dried. There is not a single drop of blood. So you understand what is spontaneous pain now. It's such heavy pressure of so much of interstitial fluid. The pulp is completely destroyed. It's just become blood and blood with all the fluids accumulated. In that scenario, you cannot do a pulpotomy, right? You have to do a pulpectomy in that scenario. Now, if the root apex is complete, then you can go ahead and finish off your pulpectomy. But if it was an open apex, then what you're going to do? Then you're going to do apexification. So materials remain the same. Everything remains the same. It's just the situation of the tooth would decide the terminology of the procedure that you're going to use. If I give you a question, a 8-year-old child comes fracturing class 3 in his front tooth, and the nerve is dead, or the nerve is alive, what are you going to do? You have to choose apexogenesis or apexification. You cannot choose pulpotomy or pulpectomy. Are you getting my point? But if I tell you a 45-year-old man comes and he just had an accident and he has a class 3 fracture now and the nerve is contaminated, then your answer would be pulpectomy. You won't say apexogenesis. What changed? The age of the patient. Because in an 8-year-old, the apex is not fully formed yet. The apex would finish formation around the age of 10 years. It takes 3 years from the time the tooth erupts into the oral cavity till the formation of the apex. So I hope this concept is clear and you will not make any further mistakes. See, if you have a to-do list, in your life, what all you want to do, if you have made a diary, I have one. Like, I have written so many things. Like, as and when I get time, I will move on to them. Do write, read Seltzer. It will make you a better clinician. And trust me, that book is not boring at all. It's really interesting. It's really nice to see what the author was thinking when he was writing. He's done so much of research. I never got bored from that book. In fact, I was more hungry to read it more because it was clearing so much of my concepts, which I applied in my clinical sciences. See, as a practitioner, we finish our studies, we graduate, we go on to practice, and we start earning money. We never go into research. Like we are doing which other people have done hard work and have actually listed the protocols that if you do this, this is the result you would get. We are never going to do a research unless we fall into academic and we have those facilities, to do the research work. So the least we can do is to honor these authors who have devoted their life at a time when so much advances in technologies weren't there. And they have made such beautiful clinical scientific evidences which helps us on day-to-day life. So put Seltzer on your to-do list. If you can get hang of that book, a PDF or hard copy, cherish it. It's a beautiful book. So I hope this is clear and this helps you. Best of luck for your exam, guys.